I think it comes back to realizing that we already treat trauma. We just don't measure what we treat. Therefore, we can't take credit for what we do. And really, I think it affects the interventions that we utilize, because you're going to find yourself gravitating to certain interventions because of what you see them do in the patient that's in front of you who has experienced trauma. And it means when the human in front of me shares their trauma, I don't feel as helpless because I know what I do can help them, and I have something to offer beyond a listening ear.
Next guest, Dr. Faith Stokes. Welcome to the show.
Thank you for having me.
Let's see if I got this right. Pelvic health and orthopedic therapist practicing in rural Georgia. You work with patients managing chronic pain, addiction, and trauma recovery. Also an educator, mentor, and one of the strongest voices pushing manual therapy toward a more trauma-informed, psychologically aware future. How'd I do?
I like it a lot.
It sounds pretty good. So far, how is your? We're at the AOMT conference doing this in person. How's your conference been? How many of these things have you been to?
So this is my first AOMT conference. So I got here last night. So I've started out this morning.
So real early.
Yeah, I'm super early
Coming
in the process.
Hot.
I am.
Okay, good. So you're actually are you the national student? In the intro, I should have said you're the national student president of AOMT as well.
No, I'm not.
That's not correct. We're gonna edit that part out.
I love it.
So help me understand with your intro. One of the strongest voices pushing manual therapy towards a more trauma-informed, psychologically aware future. What's that mean when I say that? Help break that down.
So I think the key thing for my practice recently has been realizing that we already treat trauma.
Okay, but what does treating trauma mean? Like for someone who might not understand it.
Okay. If I am considering the patient in front of me and their life experiences, have they experienced an event that was too overwhelming for either their nervous system or their physical body to manage? And are they having lasting psychological or physical results from that, something we would define as trauma? But that's part of the challenge with trauma, is if you look it up, there's so many different definitions and dimensions to one word, it's hard to define beyond looking at the individual in front of us and saying, what does it mean to you?
And it's not easy. It's going to be a different answer
every time.
Every single time. So where do you begin with that as a physical
right.
therapist? How do you begin with something that is deeply embedded in someone from an experience?
So for me, I think the key has been changing my my intake paperwork. I actually screen for yellow flags standard across all of my patients to understand how they're psychosocially coping with what's going on in their life. And a lot of times I'm finding that higher yellow flags, especially when we see pain catastrophizing or Tampa scale of kinesiophobia scores that are higher, these individuals have often experienced some event or multiple events that were too overwhelming for them to process or recover from.
What's that like when they start to reveal that in a session with you? I mean, that's probably not, that's not entry level. It doesn't feel entry level.
It's not. And then, to be honest, it might not even be advanced level, because in our profession, we are trying to do better about being trauma informed, but we don't have much training in this area. In fact, I've spent the last year studying with the psychology world and taking a lot of classes and courses with them and asking them what they wished we did better or differently to complement what they were doing, and trying to understand the tools and the screening that they use, or even the strategies they use. If a patient chooses to reveal a trauma to us, like, how do I respond so I know that I'm not going to do damage or upset them or reignite something that they're going to then have to go home and deal with by themselves?
Interesting. Yeah, I mean, how many psychology courses do we have to take to get into PT school? I believe it was one. It was intro psych.
Yes.
You needed one, and that was the one I took.
Absolutely.
Yeah. Wow, that's great. What was the reaction, or what was the response from people in psychology that you were talking to? Were they grateful that you were asking the question, or?
Absolutely.
Yeah.
So if you look at some of the individuals that are doing studies right now, so if we look at Dr. Stephen Porges, who does a great deal of psychology research, and he's looking at the polyvagal theory, he even makes the comment that one of the barriers he sees in psychology is we sit down across from a patient and we expect them to talk to us when they're not mentally in a place where they can even communicate what they're feeling. And he made the comment, what we need to do is get people up out of their chair and make them walk with us. and make them move. And that's going to cause them to be able to share their experiences a little bit easier. So I've taken that quite literally when I'm doing a subjective exam where the patient is really struggling to communicate with me. And I'm like, you know what? That's probably why they haven't done well in counseling, is they're sitting in a chair when their sympathetic is so activated, they need to move and discharge that energy.
It's really funny you mentioned that. So my background before becoming a PT was in radio. So a lot of times I interviewed mostly people in music or entertainment or sports.
Yeah.
And a lot of times they were used to being interviewed. And the stuff that I was talking about, let's be honest, I wasn't going necessarily terribly deep, right? This was about their work and things that were already public. But when I sensed that someone was a little cold, a little nervous, I would give them a tour of the radio station.
Oh, fantastic.
We'd walk around the building.
Yes.
I'd know, we're going to go out, when are we on the air? 15 minutes? Oh, cool. Hey, can I show you the studios? And we'd walk and talk, and none of it mattered, right? The goal was to get them, I wanted them to just be moving and not be still, because a lot of times in interviews, we were 90 degrees, shoulder to shoulder, facing each other, and now there's two things between us, microphones, and when there's an on-air light, like we know it's a presentation, I needed them to be comfortable with me. And I quite literally took the words, the role of guest and host. I'm like, my role as a host is to make you feel comfortable. I want you to feel welcome and lower, sort of anxiety and stress so that you can be the most you. The movement aspect, it wasn't intentional, but I was just like, this feels awkward just standing here. Let's just walk around. So I used to make an excuse. So it's funny that you bring that up. It was accidental on my part, pretty intentional on yours. And when did you ask people in psychology, professionals, why the movement aspect, what about that actually brought about better results in terms of communication?
Not necessarily. I don't know that I got to delve that deep, because when they look at movement specialties and the physiology, they looked to me for those answers.
Oh, yeah. Great.
So, which is completely fine. But if we wanted to go back to like the polyvagal theory, as they began to study that, they found that we have 3 different nerve tracts in our brain. And so for you and I to connect, we need to be in ventral vagal, which allows us to communicate, and we're relaxed, and our vitals are controlled, and our muscles are relaxed. If I'm nervous, I might start talking quickly, my vitals will go up, get red in the face, all the good stuff. But if we look at dorsal vagal, which is shut down, when we perceive a threat, so say I got so nervous, I got stage fright, I got quiet, what his theory is that you're not going to get me to connect with you unless you get me moving and get my vitals to come back up.
Interesting.
So that's been his research, is a lot of the physiology, which is why I think I've connected with his work so much, because he is looking at understanding the neurophysiology of what makes our brain and our connection work better. And then for me as a clinician, so current trauma-informed care says we should not be asking a patient if they have a past medical history of trauma, because it is unreasonable to expect them to share that trauma with a complete stranger.
Right, in the first interaction.
But he's starting to take physiological measures to say, can we predict trauma by an intake? So that's why I've changed my intake form. By the way the person sits and talks to me, the words they use, or the way they interact. Can I understand about their childhood or their current life experience? And can I adjust my care to adapt to them? Later, they may tell me about trauma. I've had patients take 6 to 12 months to tell me about their trauma. But I was not surprised when they told me about their trauma. I had been aware of it since I saw their outcome measures.
Interesting. Yeah, you got to warm up the room. It's a cold room, so you got to warm it up somehow. And however long it takes to get warm, it's not really dependent on your schedule.
Right.
It's theirs.
Absolutely.
Yeah, that's interesting. Talk about your session. What are you talking about here at the conference?
So I am talking about trauma-informed OMPT, and I'm specifically looking at how we use holistic care, manual therapy, and lifestyle medicine or education to help treat trauma. It's a little different in that I'm not covering the SAMHSA guidelines to talk about how are we more trauma-informed. There are much smarter clinicians than me out there that are well-versed in training people in this. What I'm hoping to do is provide a little reassurance to people that a lot of the things we already do treat trauma. We just don't know that that's the case because we're not measuring. We're not measuring yellow flags to see that their depression and their anxiety is improving. We're not measuring with things like Orabro to know if we need to be, excuse me, more intense early on to manage these things. So my hope with the presentation was to show practices we already use and then potentially how to elevate them a little bit with a lot of the psychology work that I've been studying over the last 12 months to say, hey, you're doing great. Here's just a few adjustments you can make to be even more trauma-informed without radically, changing your practice where you feel like you have to sit and talk with someone for 60 minutes to deliver a trauma-informed session.
We're not trying to become psychologists.
I'm not.
Yeah, we're just not equipped for it. But to say that there's no psychology coming into play in a session would be ill-informed, right? There's going to be, where with the physical comes the mental. You cannot separate the two.
You can't. And if we look at the definition, you can't. Even if we consider PTSD, cognitive processing therapy is considered the gold standard for managing that. It has less than 50% efficacy. And the issue is patients report they have physical symptom provocation during their counseling session that they aren't taught to cope with in their counseling session. Their counseling sessions aren't addressing their functional needs, so they discontinue the therapy. I find if I'm working with these therapists, I can address the functional need, I can address the pain, the physical impairments, and that allows them to stay compliant in counseling. So that's been the encouragement I've had from that field, is that our role in that is very much a primary role, not a secondary role, in helping those patients complete the therapy they need to recover.
That's great. You mentioned before we can't take credit for what we don't measure. What would meaningful trauma or yellow flag screening look like in the average ortho clinic? Maybe I'm gonna hold you to, you're not average. Okay, but what would it, could it, should it look like in the average ortho clinic in terms of addressing yellow flag screening?
Okay, I will tell you my screening process is I use the PROMIS 4-item anxiety and 4-item depression. So that's 8 questions that are very easy to utilize in a form that doesn't take long for a patient to answer, and it's very quick for test, treat, retest. I also include the Orabro, just the 10-item. That helps me identify if a patient needs additional screening like a pain catastrophizing or a Tampa scale of kinesiophobia. Those are the 3 measures I use on all patients. So it's not incredibly time intensive. I think the meaningful thing for me is what we do with that data once we get it. And when I was trained to screen yellow flags, I was not taught that I can change them. I was taught that I'm identifying them to get them to a provider that can help them. I didn't realize that yellow flags is my area to shine, and we retest those. So I retest them every 2 weeks.
That's gonna be my next question is this just on initial eval, or is this, okay, so it's every 2 weeks?
Every 2 weeks typically. If they seem fairly stable and I'm monitoring progression, it might be every 30 days. I prefer 2 weeks. I will do it weekly if the patient is unstable. But they are made aware of why I'm doing the screening.
Next question. Got it. Okay, so good. Now, how do you explain that? Hey, you're coming in for this. Why am I answering these things? They don't seem that they're related. How do you communicate that?
Absolutely. So that's where transparency in what we do becomes important, because I'll have patients that will refuse to fill it out because they've been asked to fill it out by many providers, and no one's either acknowledged the connection.
They just handed it and said, fill this out. No explanation.
And then if you think about it, like these are very sensitive questions. Like if you think of the PROMIS depression, one of the questions is, I have felt worthless. And if I say, sometimes I have felt worthless, and you say, so tell me about your low back pain, I've just revealed something very vulnerable to you that you didn't acknowledge. And so when I'm talking to patients about it, I'll often roll up next to them and I'll show them the intake form, and I will say, the reason that I screen for these is because I want to get an understanding of whether or not you are getting the support that you need to recover from this injury. And based on the numbers I see for you, you are not feeling well supported right now to recover. Is that accurate? Does it reflect your experience? And a lot of times, they may tell me one way or the other, but most of the time they'll say, no, I'm not feeling fully supported. And then I will mention to them, we have resources. I have ways I can try to get you better supported. That includes counseling, if that's something you're open to talking about. But I am incredibly transparent in what the tool measures And then I give them the opportunity to tell me whether or not that's something they identify with.
That's drastically different than fill this out on a
Yes,
clipboard.
absolutely.
With no eye contact and no context.
Exactly.
It's drastically different. You brought up lifestyle medicine before.
Absolutely.
That can be tricky for clinicians to address. There's so many different things that come into lifestyle medicine. How do you introduce topics like sleep, nutrition, or stress without sounding too invasive or like you're coming out of left field? How do you bring those in? What's the communication method for you there?
So I'm going to challenge you a little bit on
Okay.
that because I do not find lifestyle medicine invasive.
Okay.
I find it's one of the most nurturing things we can do. If I call a parental figure and they're like, baby, how'd you sleep last night? What'd you eat this morning for breakfast? You know that upsets your stomach. It's going to make you nervous before your presentation. You need to go somewhere and take 2 or 3 deep breaths. And, they're going to talk you through things they know about you as a person, and that's nurturing and that's love. But when we think about using it in the clinic, we think, oh, I'm invading their personal space. Maybe they're not ready to change here. So the way I approach it in my subjective exam, there are 3 questions I ask all my patients. I ask them how many hours a night they sleep, and do they feel rested when they wake? And it's just 2 blanket statements. I'm interested in knowing how they're sleeping. I do that within my 24-hour screening, so it seems relevant to when I'm talking about time of day that I'm asking that question. I ask them if they feel like their nutrition is supporting them right now. That gives them an out.
Sure.
They can say, yeah, my nutrition's fine. That means the door's shut right now. I can come back to that later. And then I ask them what their relationship with exercise is. And I'm interested in knowing, is it something they want to do? Do they feel like it would be supportive for them?
Super open-ended, too. What's your relationship with exercise is different than do you work out and how many times a week?
Exactly. So my rule of thumb is if all 3 of those pillars are down, so they give me a negative response to all 3, I'm doing the lifestyle medicine screening day 1. That means that 3 out of their 5 pillars are not functioning, and this human is going to have a harder time recovering well in therapy if I don't implement that early with permission. If it's only 1, it's something I'll visit maybe at a 2nd or 3rd visit. If it's 2, same thing, I'm going to get to it on visit 2. But if all 3 of those come back, we're doing lifestyle medicine day 1. And then considering that nurturing aspect, again, going back to the evidence we have, VA and the Department of Defense, within the CPG for treating PTSD after an acute trauma, the very first thing they do is assess immediate needs, and the majority of that list overlaps with lifestyle medicine.
Understood.
So if we are saying this is how we keep people from developing PTSD, we're treating trauma with that intervention. The delivery is what I have had to work on refining over the years. I have not had a patient take offense to me asking these questions. In fact, most of the time the feedback I get is, wow, no one's asked me that before. And when you have patients telling you they've eaten 500 calories that day, that completely changes my intervention for that day.
Yeah, it should.
And I'm not going to take them out and exercise them.
I sleep 2 hours a night.
Exactly.
I feel awful.
Exactly.
I haven't exercised in 6 to 12 months.
Absolutely.
These are vastly different. Right, that should change how you approach the next.
It does.
Yeah.
And when they see that change, I think that's the key thing, is when I take that data and I change my approach to them, they realize that when they tell me things, I listen. And then they don't hesitate to tell me, well, you can't have the beer, honey. Mm-hmm. And I'm like, that's fine. Keep the beer. Let's talk about something else.
Last thing we do on each episode is called the parting shot.
Yeah.
It's your chance for like a mic drop moment, soapbox statement, just one idea or concept you want to leave with the audience about everything we talked about today as we wrap up. What would your parting shot be?
To be honest, I think it comes back to realizing that we already treat trauma. We just don't measure what we treat. Therefore, we can't take credit for what we do. And really, I think it affects the interventions that we utilize, because you're going to find yourself gravitating to certain interventions because of what you see them do in the patient that's in front of you who has experienced trauma. And it means when the human in front of me shares their trauma, I don't feel as helpless because I know what I do can help them, and I have something to offer beyond a listening ear.
Love that. Faith, appreciate you coming to your first AOM tier. I hope you enjoy it. Good luck on your first day, and thanks for talking with us here in Hands On, Hands Off.
Thank you for having me.
Thanks for listening to Hands On, Hands Off, the official podcast of AOM. Subscribe now so you never miss an episode, and connect with us at aompt.org or at aompt on social. Opinions are those of the guests and not official aompt policy. See you next time.